Thank you, Scott. Welcome, everyone, to our quarterly Pennsylvania Maternal Health Collaborative. Um, I'm so happy you're here. I think you are going to find our discussion today to be very exciting, very innovative, in my opinion. We have some amazing speakers, and really mostly what we ask of everyone is to bring your creativity, your open minds, and your gift of gab to these conversations, because truly these are meant to be conversations, informal, in fact, and really sharing of ideas of what's happening across the state to address maternal morbidity and mortality. So I know I can speak for the other founders of this collaborative to say that we are very excited that you're here and happy to hear what you have to say. Our agenda today, we'll give you an update on our plan, our strategic action plan. We're going to be hearing from an amazing group of folks really focusing on the role of fathers supporting pregnancy and postpartum care, including Father Dads Matter, the fatherhood program at the Foundation for Delaware County, and the Advocates Initiative. We are going to have some breakout discussions and also want to hear from all of you and share some events that are coming up. So that's my welcome. And I'll hand it back to Scott. There's
Sure.
also CME credit, which is important, but I'll let Scott share about that.
So, welcome everyone. I'm Scott Allen with the Family Medicine Education Consortium, and we're excited to have this meeting today, as Sarah just mentioned. This meeting is approved for CME credit through the American Academy of Family Physicians. Um, and after the meeting, everyone will receive an email with the certificate, everyone who signed on. It's 1.5 hours, and all of our meetings this year through next September are approved. So if you know people who are looking for a CME or CEU credit, please encourage them to join our meetings. I just wanted to give a little bit of an update on where we have gone and where we're going. We had some leadership team meetings over the last few months and thought about our first few meetings and where we want to take them in the next year. Our leadership team is on the screen, and we're super excited to have all these great people helping us figure out what the collaborative should do going forward. We have about 180 now people who've signed up to be part of the collaborative. It's simply asking to receive information. It's not like a formal membership, but we're excited that we've got that many people from many, many diverse groups across the state. We wanted to look at our intent when we set up the collaborative in terms of who we wanted to participate and see where we were on that in those goals. And all the groups we wanted to engage are on the right of your screen. And just looking quickly a month or so ago at the people who've signed up, we are mostly the biggest group of people we have are healthcare providers at hospitals and health systems. Government is next, social service, and then there's some other groups on there. So we just wanted to kind of get a pulse for who was joining and see what we would be able to do going forward in terms of recruiting more people. So we initially had a mission statement that we could develop before we even convened the group. And we revisited that a little bit and thought about what we've learned so far and where we want to go. So we had some assertions that healthcare is well represented in our group, and we want to continue to grow that, and that this group can be a collaborative to connect healthcare individuals, organizations, with people in the community who have diverse experience and those with lived experience so that they can share and learn together. And we really want to promote in this forum that healthcare providers need to not just hear, but also listen to and integrate what they hear from community voices to achieve their intended impact on maternal morbidity and mortality and to address social determinants of health. We thought that the non-healthcare providers, the community groups that join, would benefit by being connected, being able to showcase their programs, and furthering those health system partnerships. And then we also wanted to be conscious that we're not going to duplicate the very many excellent things that are happening at the state and regional level across Pennsylvania, but want to kind of inform them. So as we learn things through our meetings and you all share with us your great strategies and your suggestions, we'll be able to carry those forward to the other groups, such as the statewide strategic plan that we'll hear about later today. So our goals for the next year are going to be to continue to include groups and individuals who might not be able to participate in some of those other statewide and regional meetings that are going on. We kind of think our quarterly hour and a half meetings are fairly easy to join. So we're hoping to make this group get bigger. We're going to continue the quarterly meetings in the 90-minute format. We really want them to be educational, hence going ahead and getting continuing medical education credit. And share the voices and the needs of end users, community voices, people with lived experience, so that everyone can learn from them. And we're also going to try and more formalize what we're doing. We've just been going about this for about a year. Great leadership team, but we're hoping to bring in some resources to be able to kind of capture and report and move forward on some of the great ideas that you all share with us. So just quickly, we do have some tentative dates for the next year of meetings: January, April, June, and September. And we've looked at some topics we want to address. They're on the screen. These are all not set in stone, but we're going to be working on them as we go. And we wanted you all to think about them, simply because you may know people who could speak, you yourself or others you know might be great people to speak on some of these topics, and just give us advice on what you want to hear at some of these meetings. So with that, I'm going to turn it over to Giselle Alden from the Pennsylvania Department of Health to talk about the strategic plan.
Thank you, Scott. Good afternoon, everyone. Like Scott said, my name is Giselle Halden. I'm the Director for the Division of Maternal Health Services in the Pennsylvania Department of Health. Sarah Goulet, who usually gives this update, is unable to be here today and asked that I fill in for her. So the Healthy Moms Vibrant Future, which is Pennsylvania's Maternal Health Strategic Action Plan, is in the final stages of layout and will be accompanied by a website with additional information on maternal health. The plan is to formally announce all of this after the budget impasse ends. And the plan will be shared with the Black Maternal Health Caucus in advance of that public announcement. Slide, please. So as you're likely aware, Pennsylvania has 5 priority areas we're working to improve on in the maternal health space. Improving access to high quality care, improving behavioral health in the perinatal period, improving resources in rural communities and maternity care deserts, health-related social needs or social determinants of health, and improving and diversifying the maternal health workforce. Slide, please. So we can talk about this as much as we want, but what we really need to get the results is action. So implementation is the primary focus of the PAC, or the Perinatal Action Collaborative, which is the action arm of the Maternal Health Strategic Plan. And that's a big piece of all of this. So the PAC is made up of stakeholders, providers, community-based organizations, and individuals with lived experience. Slide, please. PAC members are tasked with looking at each priority area and developing actionable strategies to address that priority, including the identification of partners who are able to actually execute the strategy. The first 3 strategies, behavioral health, rural and maternity care deserts, and access to high quality care, met from June to August to do this work. And the recommendations were then presented and approved by the PAC as a whole in September. As we were working through this, the PAC really wanted to have recommendations expand on existing programs or infrastructure in Pennsylvania to make the most of the time and funding that we have available for this project. Slide, please. So the recommendations for the first 3 priority areas were for behavioral health screening, and a comprehensive app that with navigators, as well as additional training requirements for providers working with the perinatal populations. Slide. Rural health and maternity care deserts, educating the community on types of available providers and what they can do for an individual during that perinatal period, as well as expanding mobile units, virtual care, and other non-traditional approaches to receiving care in the perinatal period. Slide. And increasing access to high quality care is working to build capacity for referrals to doulas and community health workers and home visitors, as well as fund programs around other sort of available supports in the perinatal period. Okay, slide please. So where we're at currently, there is an RFP posted for funds for programs to address the needs and strategies that I just went over. And those are due to the Jewish Healthcare Foundation by November 17th. The PAC priority team members and our lived experience members will review and award subgrantees from the RFA applicants for the projects, and the start date will be in January of 2026. And the other two priority areas, which are social determinants of health or health-related social needs and workforce, are currently meeting and will finalize their recommended strategies in the coming months. Slide, please. So going back to my comment about working from existing infrastructure, a couple of shameless plugs. If you have an asset that could be identified, please scan the QR code or go to the website and add your organization. The more assets that we have listed, the more knowledgeable we are about available maternal health services in Pennsylvania and can share that with everyone. Slide, please. And the same for PA Navigate. If you or your organization isn't currently listed in here, please consider adding it to PA Navigate. Both of these will aid in expanding access to care for this population, which is what we're all doing here. So, slide. Okay, and thank you. And again, I'm not Sarah, but they were her slides. So I'm happy to take any questions if there are any, or I can attempt to answer in the chat. Thanks, Scott.
Okay. If anyone wants to unmute and ask a question or two, we have a few minutes for that. Great. And if not, feel free to put your questions in the chat at any time. And with that, I'm going to turn it over to Dr. Saunders, who's going to introduce our speakers today.
Thank you, Scott, Sarah, and Giselle. Great stuff there so far. I get an opportunity to introduce our three speakers. I'm going to do them individually, all to discuss how fathers are supporting pregnancy and beyond. So we're going to start with Dr. Adobe Anakwe, who is from Drexel University, and she's going to talk about her program, Black Dads Matter.
Hi, everyone. My name is Dr. Adobe Anakwe, and I am an assistant professor at Drexel University, Dunside School of Public Health, and I'm also the principal investigator for the Helper team. I will talk more about my team on the next slide. But I just wanted to thank you all for being here today and for all the support that you provide to birthing families. I'm excited to share what my team and I have worked on over the past year. Next slide, please. But before we proceed, I'd like to disclose that this presentation uses a gendered language for clarity and alignment with the literature in this field. This usage is not intended to exclude, misrepresent, or diminish other gender identities. Next slide, please. So before we delve in, I would like to acknowledge the wonderful group of people, students, community partners, and colleagues that I've had the pleasure of working with as part of the Helper team. Helper stands for the Health Equity Lab for Paternal Education and Research at Drexel University. And this work would not be possible without their efforts. Information on how to connect with us will be provided at the end. Next slide, please. All right, so this is just an outline of what we can expect to hear from me today. So I'll talk a little bit about a background, and then the two studies I'll kind of touch on, and then we'll draw some conclusions. Next slide. So I have some learning objectives. I'm hoping that by the end of this presentation, that we'll have a shared understanding of the unique challenges that Black men face during their transition to fatherhood. I also want us to have an understanding of the current state of the research, especially around Black men's health, during this time. And then hopefully we get to identify some opportunities for improving paternal health as well as maternal and child outcomes. Next slide, please. So this is the first study that I'm going to touch on throughout this presentation. I'd like us to know that when I use the term Black, I am referring to Black and the African diaspora, including African Americans, Afro-Caribbeans, Africans from Africa. This approach is taken to fully acknowledge the heterogeneity of Blackness that my work represents. Next slide, please. So we may ask, why do we need to understand fathering experiences and perinatal health consequences for men? We know that there are persistent disparities in pregnancy-related outcomes that disproportionately burden Black mothers and babies. And then increasingly, evidence points to fathers' contributions to these outcomes. So biologically, research has shown that men's semen quality can influence their offspring's genetic profiles. So for instance, paternal preconception metabolic syndrome diseases, including hypertension, hyperlipidemia, diabetes, and obesity, have been associated with early pregnancy loss and infant low birth weight. When we think more psychosocially, the lack of paternal support has been associated with increased maternal depressive symptoms, and paternal depression has also been associated with preterm birth and lower cognitive function of the child. Usually, when we think about fatherhood and pregnancy, we often think about how fathers impact mothers and their children, and less often do we think about how pregnancy affects fathers themselves. But some of the studies that have looked at this have suggested that fatherhood may confer health benefits to men in certain areas, but not in others. So for instance, becoming a father has been associated with increased weight gain and poorer mental health. However, it has also been associated with reduced alcohol use. However, Black men navigate additional unique challenges to both their fatherhood and optimizing their health. So the persistent negative stereotyping of Black fatherhood, especially in American society, has likely impacted its emergence. The other challenge is that current studies on paternal prenatal health often assume a homogeneity of men's experiences, which then ignores, the influence of other experiences like racial discrimination, colonization, and cultural variations. Next slide, please. So given this background, my interest was to understand how do Black men, I'm asking this was my broad overarching research question. So how do Black men navigate their health in the context of childbearing and child rearing? And in order to contextualize and unpack Black fathers' unique experiences, I apply 4 paradigms and conceptual frameworks. Don't worry, I'm not going to talk about all of this in depth, but it's just to give us an understanding of how I approach this work. So I think about, I apply the public health critical race praxis and intersectionality frameworks. So looking at men within the context of Black and father and the social conditions that differentially affect them within the social locations. I also apply the life course framework, thinking across the reproductive continuum. And then I try to bring these together in the integrated perinatal health framework, which examines both distal and proximal biopsychosocial factors that can impact Black fathers' health. Next slide, please. So when I use this framing, or when I use these lenses to look at Black fathers specifically, we then identify other factors that are unique to Black fatherhood that necessitate a nuanced examination of their transition to fatherhood. So for instance, we know that Black men have poorer overall health and shorter life expectancy. We also know that preconceptionally, Black men have poorer health than their white counterparts. The racially defined negative context of Black fatherhood, like I said before, especially in the US context, they have contributed to shaping their health and wellness across their reproductive continuum. But too little is known about how fatherhood can differentially predispose or protect Black men's health. And this is important because it is, an important pathway yet missing in understanding Black maternal and child outcomes. So all of this background has led me to these two research questions, right? And the first question was to understand what effect the transition to fatherhood has on Black men's mental and physical health, as well as their overall well-being. And I also wanted to understand in what ways individual, relational, and contextual experiences influence Black fathers' health during their transition to fatherhood. So our first approach to this work was to conduct a systematic review, that is, examining all of the published literature to date that have asked about Black men's health during their transition to fatherhood, to examine the extent to which Black men's transitioning experiences and the consequent health outcomes are documented in the literature. So we conducted our search up to January of this year. And the studies that were included were original, empirical peer-reviewed research studies that reported explicitly on Black heterosexual men within the first 1,000 days of birth. So from pregnancy up until the first 2 years of life of their child. We also applied an organizing framework to help us articulate the extent to which the existing evidence or the existing literature represents Black men. So we documented their place of residence, their race, ethnicity, culture, language, occupation, gender, religion, education, socioeconomic status, etc. Next slide. So after our literature search, what did we find? We identified 22 studies with a total sample size of slightly over 10,000 people, but only 21% of men in these studies identified as Black. What we did see is that most of the studies were conducted in the US and some in the UK. Participants across the studies were between the ages of 14 to 60 years. Most studies talked about their educational attainment and their employment status, but not very many talked about occupation, religion, and social capital. In terms of the health domains assessed, we found that 7 studies reported on biophysiological outcomes, while 15 studies reported on their behavioral and mental health outcomes. Thinking about the other domains of experiences, 9 studies looked at or talked or reported on the individual level experiences. 10 studies talked about relational experiences, and another 10 studies talked about their contextual experiences. Next slide, please. So given our first research question, so here more explicitly, I present here the different health domains assessed in the studies. Specifically in the biophysiological space, we see that many fathers reported, only one study reported on acute disease onset. We have 2 studies that talked about CUVADE, which is the psychosomatic symptoms that men sometimes present that mimic pregnancy, like similarly to their partners. And the last time, the studies when we searched, the 2 studies that highlighted this finding were conducted in the 70s and in the 80s. In the behavioral domain, the most frequently reported health outcome was mental health. So 10 studies reported on this, talking about stress coping, depressive symptoms, and emotional health. But the summary or the takeaway from this slide is that Black men have poorer overall health outcomes during their transition to fatherhood compared to other fathers. Next slide, please. Okay, so I'm going to acknowledge first that this is a busy slide, but this is reporting on our second research question. So in the individual domain, what we did see was that most men experienced a roller coaster of emotions during their transition, but through it all, they valued their fatherhood in spite of any setbacks, such as educational and occupational setbacks post-fatherhood. In the relational domain, we see that fathers experiencing significant conflict with the mother of the baby or their partner reported depressive symptomology. However, there were other relational factors that were highlighted, such as conflict with the grandmother and also with their own father. In the contextual domain, the most prominent contextual factor that influenced fathers' experiences were their exclusion by healthcare workers and health systems. So the key takeaway, again, in summary, what we found in this through this research question is that Black men do value their fatherhood, but face significant challenges in the relational and contextual domains that negatively impact their health. Next slide, please. All right, we have a couple of takeaways on here, but the one I really want to highlight is the blurb in pink, which says that transitioning to fatherhood has more negative health effects for Black fathers, and these health effects are likely explained by their unique contextual experiences. Next slide. So following what we learned about the transitioning to fatherhood in our systematic review, so transitioning to fatherhood and Black maternal health, right? We now want to understand what that looks like in Philadelphia. So we're currently conducting, this study. So if we could go to the next slide, so I can talk a little bit about this. So what we are doing is, so the goals of the study actually is to first assess how Black fathers living on low income between the ages of 18 and 29, how they are thinking about their health and wellness within the context of fatherhood. We're also interested in exploring their experiences and their needs during this time. We also want to identify what resources and what support systems they have utilized, what's available and what they're actually utilizing. But we also want to capture stakeholder perspectives on these experiences. So in order to conduct the study, first we began, previous slide. So we began, yes, thank you. We began by identifying the areas with the poorest health and birth outcomes in Philadelphia, right? And so these areas are highlighted with the darkest color. So North Philly, West Philly, and Germantown. So that's where we conducted our recruitment. Okay, next slide. So we're using a qualitative approach to address these research objectives. And we've recruited 14 stakeholders. These stakeholders are leaders of fatherhood-focused organizations, healthcare providers, and policymakers. And we also recruited 11 fathers. We actually just concluded data collection in September. So data analysis is in progress. So I am looking forward. I don't have any findings to share right now. I am looking forward to next steps once we are able to finish the analysis of this data to, hopefully come back and share our findings with the collaborative. All right, next slide. So thank you so much for listening, and I'm, acknowledging all those who have contributed to this work in different ways and supported our study. All right, next slide. Here's my contact and open for questions. Thank you so much for listening.
Dr. Nakwe, I'm just fascinated by all this information. Really good stuff. And I know you have more to come. So I have questions, of course, but that's just my selfishness there. And I'll follow up. Others, and Scott, if you can call on folks if they raise their hand and I miss it. Any questions from the audience? I will jump in though. Let me know if I missed a question, Scott and others. But
I think we have one. Leah Johnson, do you want to unmute and ask?
Yeah, thank you so much. Alea Johnson here. Thank you so much for this presentation. I think this data is really interesting, and I'm excited to hear about the findings that you guys have for the data that you're reviewing right now. I think one of the things that popped up for me is I know that this work is specifically for, like Black perinatal health. I know in the literature review, I think you were mainly focusing on heterosexual men. I guess I'm just wondering if there's any if there's any plans to include any sort of like LGBTQ families, and knowing if there's like a significant enough population to include like any sort of differences in their health outcomes, going forward.
Going forward, I would say definitely. However, why we started, and thank you so much for that question. It's a really great question because trying to get into this work, you had to kind of focus and decide like where do I start because there's a lot to do. So the focus on heterosexual men was just understanding the context of how fatherhood has been framed traditionally. And for me, it's like, okay, let's think about if we are working with a society that thinks about traditional family systems and traditional family structures, if we're comparing apples to apples in terms of the only variation being racial identity, right? What does that look like? And what are the challenges? Because I think that what we learn from here will give us insight into the different ways or the different nuanced approaches that we could use with other populations. I hope does that answer your question?
Absolutely. And that makes so much sense. Honestly, I think so as well, because there are just different things that pop up in LGBTQ communities that like change the role of caretaking in general, and like remove a lot of the traditional gender roles that you guys are like impacting and analyzing right now. So I guess my brain goes to like, okay, so this will be the foundation, and what are the next steps, and how do we explore those nuances? Because I think in those nuances we also often get solutions.
Absolutely. Thank you.
Some real good stuff there. We will definitely hear from Dr. Anakwe going forward. Looking forward to seeing, some more of the results. I'm very interested in a lot of things about this, but the differences, the nuances between, say, an African American, someone from the Caribbean, someone from the continent. I'm also interested in, I mean, if you were to do a retrospective and looking at generations, so say my father, his father, me, my son, when perhaps he has a child, and what the generational differences as it relates to our health and the impact of the healthcare industry. And so, really fascinated by this, Dr. Nakwe. Appreciate the information and look forward to hearing more. And hopefully you'll stay in touch with us.
Absolutely. I'm looking forward to it.
Fantastic.
Yeah.
So now we're going to segue to Dr. Muid, who's going to talk to us a little bit about the fatherhood program through the County of Delaware, at the County of Delaware, through that foundation. Dr. Muid?
Yes. Good afternoon, everyone. It's certainly a pleasure and it's an honor to be here with such a distinguished panel. I think my wife would want to be here to hear me say that I don't even want to talk because the last presentation has me so much interested that I want to hear more. But since I've been asked to present, I will go ahead and painfully do so. So I'd like to talk about engaging fathers throughout the pre and post pregnancy cycle using what is called the life course approach. Next slide. And for those of you who may not be aware, the Foundation for Delaware County has a number of public health programs, including Healthy Start, Nurse Family Partnership, Delaware County Women, Infants, and Children WIC program, as well as a health resource center at Chester High, Cribs for Kids, and the Center for Hispanic Resources. I said the Foundation for Delaware County, but I'm going to also let you know there's been a change, and I'll tell you that change probably at the end. Next slide, please. So the life course approach looks at 1, 2, 3, 4, 5 distinct transitional periods throughout the whole pregnancy process. And we're going to talk about each one of them. In this context, fatherhood involvement can be understood as a positive and active participation of the father or partner in the lives of his or her children and family during the pregnancy and as the children grow up. This is a Healthy Start definition. As you know, Healthy Start is one of the home visiting programs that the foundation actually manages. Next slide, please. So preconception health is really a time to talk about the social determinants of health. That is, how is that father and his family and that community situated in the social, economic, political, and certainly historical environment. Preconception health refers to physical, mental, emotional well-being of the individuals before they attempt to conceive, and in many cases, it's not usually planned event. More often than not, it's like, oh, we're pregnant, and involves taking steps to optimize their health and reduce potential risks for both the mother and the child, and certainly the father as well. So this preconception period is very important because it talks about the general life of the individual over a period of time. And of course, it does include intergenerational realities that that person is experiencing and maybe not be fully cognizant of all the different aspects. So we're talking about historical trauma. How does historical trauma play into the lives of the populations that we serve? Next slide, please. When we speak about, and it's been, mentioned a few times, determinants of health, the social determinants of health, it's been found that social and economic factors account for up to 40%. Genes and biology, which, believe it or not, is only about 10%. The physical environment, 10%, and clinical care, 10%, and health behaviors, 30%. So we're seeing that all these factors combine in terms of impacting the health of that individual. We also know that looking at studies of redlining, most of the areas in which we find highest levels of infant mortality and maternal mortality, in fact, correlate with those places in which redlining has been the historical narrative. So if we look at that critically, what we're saying that there's been an extension from the slave plantation system into the ghetto system, where these particular individuals have the same type of profiles, highest rates on lowest protective factors. Next slide, please. So moving into prenatal health, right? This, of course, refers to not only the medical care that we're expecting the woman and the family to partake in, but also doula care. It is good that finally Pennsylvania has agreed to pay for doula services and through Medicaid. And this is a major improvement in terms of providing sources. I'd like to recommend and put forth the notion that with a new Black birthing model, might we in fact see the midwife, see a doula for her, as well as a doula for him. Okay, I'm a doula in training. Still got to take that test and, still have a few cases to actually present. Well, we see an increasing interest by men to become doulas, which is beautiful. But the new birthing model would include the midwife, the doula, the doulo, lactation consultant, and possibly a health coach to work as a team. This, if anything else, I've only been in the public health arena for about 5 years, but primarily doing behavioral health for the last about 35 years. But if anything, my hopeful contribution is to create consortiums such that not only seeing these functions increase in terms of number, in participation in terms of scholarship, but actually working as a care team. All of those individuals working together. There's no such entity where those things have been fused as a solid care team. So I'm hoping that that can take place. Next slide, please. During the postpartum period, right, after the birth. And we are seeing a higher level of fathers attending the birthing process, being in the birthing room. Of course, we saw a terrible decline during COVID because of hospital regulations in terms of who could enter the hospital at the time. But we're seeing an uptick in terms of fathers actually attending. In fact, I've noticed a lot, believe it or not, I've noticed a lot of young men going to the baby showers, which is a new thing. My generation did not do that. We did, first of all, we wasn't even invited. Not sure if we would have went if we were invited, but we weren't invited. Most of us did not. Um, but I'm seeing a change in the younger culture in terms of young fathers being involved, and this is I think it's related to also um, dispelling the myth. The myth is that Black men aren't involved with their children. In fact, CDC did a study and found, some of you probably know this, found that Black men were more involved with their children than any other race, which certainly goes against the public narrative. So it's really fighting these myths that is so important. So in the postpartum period, we want to certainly look at the physical and emotional health of the women and the father as well. And you notice that I bolded social relation and physical health. And the reason I boldened relational health in this period is because it's in that relationship that comfort is given, is in that relationship that understanding is afforded, is in that relationship that people don't feel, that the woman doesn't feel alone. So it's so important for the father to be cognizant of his own emotional health. Now that's a challenge. It's a challenge because men are emotionally illiterate. We live in a society where the women as well as the men tell the boy, stop crying. Boys don't cry. Man up. So we live in a patriarchy society that takes away a human aspect of the boy, and therefore it's not there when he becomes a man. So how can men, in fact, know their own emotions if they haven't had a culture or a family, a tradition where that is actually emphasized and brought forward? So I go to George Hill Correction Facility. This is in Delaware County. And part of my fatherhood training is to make sure that I have a whole session on emotions. And then also the other side of that is the grief part. Um, when a woman loses a child, the father loses a child as well. But usually there's no places for them to go. I work with a group called the Lexa Collective out of New York. The film is called Aftershock with Shawnee and also Omari. And Omari has created. He lost his wife, and we have a support group. But far and few between do you find places where men could actually speak about their emotions, nor and also their grief. And this is something which certainly needs to be attended to. In the postpartum period, we know that men also can experience postpartum depression. Very few places for them to go to discuss that. So we're talking about how do men, in fact, participate in all these aspects of uh, the um, the life course process, and it's also therefore saying that we need to check up on the men to see what they're doing. Next slide. So I want to take 2 minutes to look at a very important area, which is breastfeeding or chest feeding. And you'll hear from a few fathers who are more than willing to express their agreement and support for their wives to actually breastfeed. Now, let's see that clip, please.
I'm all for breastfeeding. I just felt it was my job to, be her backbone, and yeah, I try my best to do that.
Seeing her grow I'm more aware of her growing from when she was a day old to now, and I'm like, wow, she's getting everything that she needs from the breast milk.
Changing the diapers, taking the baby from her when the baby's fed, helping her birth the baby, helping to clean up, um, giving her that downtime. So when she's finished feeding the child, then I could just take our child and just go off somewhere and give her that downtime.
Well, I know she needs rest. I'll take the baby and play with him and entertain him while she gets her rest.
I sing to her because I'm a singer, so I sing to her. You are my treasure.
There was a lot of things I didn't know, and I think with me having more knowledge about breastfeeding and things of that nature, WIC really helped me out to help her out.
It is a challenge being with a military member, but I believe she was able to find the information she needed, get the support she needed, talk to these military moms, talk to the WIC counselors as well.
I think WIC is has a great staff, and I think it's a great thing that they're doing. I would tell them to go ahead and check out WIC.
Well, you have to take it day by day. Yeah, you're going to get there, but it's going to be a process, But again, yeah, just take it one day at a time and just keep pushing and staying positive.
I would like to get a time check. How much more time do I have?
I'm going to say 2 to 3 minutes because I'd love to get a couple of questions in.
All right. So, postpartum health, of course, chest feeding. I couldn't find a video to show that part, but of course, placing the baby on the man, placing the baby on his chest and having the bottle, hopefully that is breastfed milk that's in there, is a very important step as well. Next slide, please. I spoke a little bit about postpartum depression that men experience. And this is a time when depression, just the emotions just doesn't seem to sink. And men find themselves in a state of confusion, state of loneliness, and therefore we need to give them attention as well. Next slide. Interception, of course, after the baby is born and we make that transition in terms of the type of doctor in which the mother is being seen is a very important step that most people kind of leave out. We here at the foundation, we see this step as being important because if the relationship between the men and the women, the father and the mother, isn't going well, of course, that's going to have a lasting effect on the baby's emotional stability as well. Next slide. Interception is a period of critical time for the infant and the parents. Next slide. Also, I want to introduce, for those of you who might not have seen the concept of interoception, is understanding the body's internal senses, right? I mean, your body, you feel hungry, your body growls, you know there's something going on. And we know this is so important because when women complain about things which they're feeling in the hospital, they're overlooked. And this is why CDC said that 86% of those maternal deaths were avoidable. I mean, when you think about that, it's almost like low-level genocide. When you know a condition exists and you don't do anything about it, it's really quite horrific that that's taking place. So it's important to take, pay attention to what the woman is saying all throughout the whole pregnancy period, and certainly postpartum as well. In fact, 50% of the deaths occur after the baby is born. So it's not just during the birthing period or just right after. It's really that whole year. And this is why we're talking about having a fourth trimester. Next slide. Of course, this goes into parent and child development. At Healthy Start, we work with fathers up into 2 years of age, actually 18 months of age of the child. With Nurse Family Partnership, we can go up to 2 years. But after that, they kind of fall into an abyss because there aren't any services here in Delaware County other than early Head Start and Head Start. But certainly I'd like to talk more about that, but time is running out. Next slide. So we're talking about sustained strategic engagement of fathers in the area of policy, in the area of programs, in the area of practice. And of course, we want to increase the fathers, the number of fathers, the quality of time that they spend with their mate and with the child. And we know that we have to have public programs such as Parents Cafe, Dad's Cafe, and include baby showers. Next slide. Um, we know that father involvement has an impact on both pregnancy and infant outcomes. And of course, we want a greater father involvement. And it takes time to do that because fathers have been summarily just disconnected and, in fact, not invited. Next slide. And this is why I introduced the term father equity, right? The history of benign neglect uh, in terms of maternal and children's services. When we talk about WIC, women, infant, and children, where is the dad? Right. We know that last funding mandated fatherhood inclusion after 20 years, right? So we know we have to increase services for dads so that they can not help the mother, not support the mother, but in fact assume their responsibilities as a father, as a dad. Next slide. These are some of the resources that will be made available to you in terms of where you can go and see where some good things are happening with respect to father resources. Next slide. And with that, I'd like to say thank you for this invitation, for the time, and that's how I can be contacted. I did say that there is a change, and that is we have migrated our home visiting services away from the foundation proper, and we have our own designation as now we are known as the Family Village or Family Village. Thank you so very much. If there are any questions, I'll be more than happy to entertain. Thank you.
Wow, Dr. Moed, you talked about as you entered in painfully presenting after Dr. Adobe. You did a fantastic job, opened up a lot of questions I have, a lot of thoughts and ideas that I have. I'll put out here in front of everyone. We clearly need to have some sort of program for dads. I know there are some things out there. I'm going to hear from advocates shortly, but there needs to be some sort of concerted fatherhood, Black men in general type of effort going forward. So
If I can share with you,
please.
I just earlier this year I just completed being the recipient of the first fellowship to become what is called a mentee of the National Community. I'm messing up the name, with Dr. Johnson down in Maryland. He's gonna kill me. But anyway, we graduated, and my research was looking at fatherhood in Delaware County and also proposing a national fatherhood research, healing and empowerment coalition. And I started to do it just for Delaware County, but I'm saying, wait a minute, all the counties needed, and I was already involved with national networks. So I will be forwarding that information to you, what my capstone was, what I intend to do, And if interested, I can even do a presentation on that at some time in the future. But thank you for bringing that up. Yes, we do need these spaces. But in the coalition, I talked about creating a particular part of it that helps fatherhood professionals. There's very little things for us to deal with our own issues and how we're helping other fathers. So thank you so very much for that extra time to put that in there as a plug. Thank you.
Oh yeah, and I'll say this for the audience. We're going to not have our breakouts because this conversation has been so robust. We hope that all three presenters, and you're about to hear from Venus Ricks from the Dad Advocates program, but that all three of our presenters can stick around. We're going to have a discussion that Dr. Ramirez can facilitate. But yeah, we'll forego our breakout because this discussion is very was fascinating, very interesting. So just a couple of things. Well, do we have any questions from anyone that I'm missing? Scott, anyone would like to ask any questions right here?
I don't see any hands up, but if people want to put them in the chat after we move on, that'd be great.
That'd be fantastic. And I'll just say just a few things. One, the doula for him is a wonderful idea. I mean, men tend to be that forgotten partner, if you will, not from this team, but from I think the general environment, the general healthcare team is something else that you mentioned. I really like that in regards to doula, midwife, and father equity is a wonderful new term for me. Getting men involved in encouraging breastfeeding and understanding breastfeeding. You also mentioned, so we've heard it twice, the life course approach. So we have so much more to delve into. Dr. Muir, hopefully you'll stick around for this conversation today and just continue to engage with us going forward. We're hopeful of your continued engagement.
Most definitely.
Sounds good. Okay, well, now let's move to Venus Ricks with the Dad Advocates program. I went to the first session, when was that, Venus?
September
2 months ago.
13th? Yeah.
Then, and I'm going to drop by tomorrow. Yes, tomorrow as well for a little bit. So I've seen this in action. Let Venus tell you all about it. And Dr. Shree Livingston, who could not be here, she's out in front of this, and they've done a fantastic job. So Venus.
Good afternoon, everyone. I am so glad to be here representing Patients Are Waiting, Patients Are Waiting's Diversifying Doulas Initiative. I want to start with just giving you an outline, not talking a lot about me. I'm Venus Ricks. I'm, again, here representing the organization and telling you about Advocates and also what the organization does. But before I get started with kind of the technical information, I want to talk with you a little bit about thinking through this as you are focused in on the presentation, that 2026, the Black Maternal Health Week theme is joy. And so as we think of these issues, particularly in supporting Black men and understanding what Black men are experiencing during the perinatal care process, we have to think about at the end of the day, we are working, right, for maternal health equity to bring joy back to families, right, to encourage more joy. What is more joyful than a healthy baby? What is more joyful than bringing a healthy baby home? What is more joyful than having support from your partner, support from that person that you are bringing life into the world with? And so you'll also notice that I'm using very gendered language, and I'm also focused in on Black men. That is not because no other group is important, but we're starting with who is on fire. What communities' outcomes are the worst? And you have to start there in order to inform other communities of color and other groups who are experiencing similar issues. And so I wanted to preface the presentation with that. And with that, please, next slide. So eliminating health disparities. The mission of Patients Are Waiting is that we believe the part of our commitment to eliminating health disparities also includes increasing access to healthcare that improves health outcomes. How do we do this? Eliminating health disparities by increasing diversity in medicine, increasing the pipeline of minority clinicians, making the pipeline of minority clinicians less leaky, and supporting minority clinicians in practice. And so the organization is founded and run by two OBGYNs, Dr. Sharice Hamblin and also Dr. Cherie Livingston, as you just heard David Saunders speak of. Next slide, please. I can't see the chat, so if anyone needs me to focus on that or put your hands up or anything, if David or Scott could help me out with that, that would be great. So another part of what Patients Are Waiting is addressing is the maternal mortality crisis. And we're doing this as an organization through providing birthing people of color with doula support. Through the initiative, we are placing birthing people of color with experienced doulas fully subsidized. We also train those doulas in-house and have a trainer that comes in and does their hands-on weekend. So they get both academic coursework as well as a hands-on weekend that prepares them. The benefits of this, as I'm sure you all know, being connected to a collaborative like this is reduction in anxiety, lower C-section rates, and much more. And as we're talking about supports, right, emotional well-being, if we have to be clear, folks really got hit harder during COVID-19. And so we're doing both work to rectify things, but then also what are the support places and the care spots where humans are not getting their due. Next slide. Diversifying Doulas Initiatives has four areas, 4 arms and 4 areas of focus. First, we have the training and services. Those are 2 areas that work together. So as I mentioned, we're training doulas and we're also providing services. And so anyone that applies for the program and gets into the doula training initiative, you will have your training subsidized. Same thing with services. And right now, the organization is serving 4 primary counties, not only those counties, but because we are attracting those who are interested in serving in those counties, those are the folks that have been trained thus far. And so Dauphin, Lancaster, York, and Berks counties are being served by the organization and by the initiative. And I'm here today to talk with you about the research piece. And then we also have the community piece where we are taking what we're learning from training, from services and research and bringing it out to the community in a program that we are referring to as For You by Doulas. So the doulas are also trained and go out and do education courses and education circles for local pregnant folks, those in postpartum, and those thinking about being pregnant. And just to plug, our next training session, info session, is January 14th. So think about it. Thank you. So this slide shows kind of real-time data of how we are serving clients and how the services are benefiting them on the back end. And so 74% of our patients deliver vaginally. A little over 25% of our patients deliver by C-section. And if you can see the number here, the Healthy People 2030 national target is 23.6. So that's a very good number. I mean, of course, we wanted to be more aligned with that, but I think that's a pretty decent and beneficial number to put out there for folks to see. And then as we talk about preterm deliveries, 10% of our patients have preterm deliveries. So these are wonderful statistics that we are able to get as we are serving people and as we are training doulas. Next slide. Ooh, so now to the research. Ooh, where'd that H? Excuse that H. Formatting is a mess. So population, Black men. As I said before, we are focused in on Black men because that is the house that is on fire. And you want to make sure that if you understand why this house is on fire, you'll be able to support and make outcomes better for other populations as well. And so we want to be intentional about what we're doing. And so in that intention, it's to explore the experiences and needs of Black men as they support birthing people in their lives during perinatal care. And so we're looking for grandfathers, fathers, uncles, cousins, anyone that has had, because we know in certain communities and certain cultures, right, it's not just the mother and the father or the parents, right, depending on how that gender shows up. It's not just the parents that are helping. It's also the mothers, it's the grandmothers, the grandfathers, the uncles. It's all those people. So if we understood more about what the men are experiencing, what do they need? How do they understand this process and where they fit? We can create and have some interventions and develop some things that will better the outcomes for this population. Some of those developments include a daddy doula cohort. I know we heard in the last presentation about having daddy doulas. He did not call it daddy doulas, but that's what we're referring to it. So we are looking to have this research between the listening sessions we've had and other research pieces. How do we create a daddy doula cohort that speaks to the needs of men as they're supporting their partners, as they're supporting their families through this process? Also educational materials. And we know what else is important, right? Policy recommendations. How will this then inform policy so that Black families, Black men have a better experience and that there are better outcomes for their families? Oops, sorry, you have to change the slides. Next slide. So, family-centered perinatal care, right? We understand statistics. Statistics tell us a lot. And Black women experience maternal mortality at a rate literally 3 times that of white women. And so when we think about how men fit into that, research has shown that there is a link between giving men what they need, or excuse me, Black men what they need in order to support Black women as they are becoming mothers, as they are transitioning to home, and as they're experiencing that postpartum, right? We know that postpartum symptoms in the period, that's the period where we're losing folks based on maternal mental health. And so what would it look like to have stronger emotional support, not just from doula care, but from a doula, right? A woman as a doula, a man as a doula, and then have that wraparound support for the family. It's not just a one-sided thing. And there's a short video here that I'd like to show from our last Dadvocate session, folks talking about their experience and what that brought them to the presentation, or excuse me, the event. Maybe.
Venus, I wonder if you might be able to show it on your screen. I think because it's not going to play for mine.
Okay. Give me 1 second. Thank you for your patience.
Hi, my name is Andre, and I support DDI advocates.
Hi, my name is Stacy Bevel, and I am a birth and postpartum doula with Copper Sky Doula. My husband and I came out from New Jersey to support the DDI initiative and advocates. When I was working with clients, the husbands were just kind of staring at the ceiling. And so I pulled my husband in just to ask him to talk to the dads and to give them some information. And my husband's been a longtime mentor. We've been doing some work. He's like the doula for our company, but what we realized is that we're kind of the pioneers. We're the lone rangers out here. So we came out from New Jersey to support this, but also to gather more information so that we can take it back.
Hi everyone, it's Brene Gray. I'm here with the DDI, volunteering here for Dadvocates, a program dedicated to helping fathers. Not only do doulas help mothers, but we also help fathers. The father is a very important role in raising a child, and we want to continue to push that narrative.
Okay, Scott, I won't make you share the rest. There's only one more slide. Here we go. So before I zip my lips, just wanted to give you a few other things to think about, particularly around statistics. So as I mentioned, right, mental health conditions are the leading cause of maternal mortality. Non-Hispanic Black women rank second highest for reported postpartum depression symptoms. And Black men are underutilized despite evidence linking them to being actively engaged in improving outcomes in maternal health experiences. So as we think about that, right, if men are able to help produce children, how aren't we allowing men to be at the center of that experience, right? Not centering men, but putting them in that experience and what they're going through as they're supporting those in their lives. And with that, right, that emotional need, that emotional support. The gentleman you saw in the video, we got to meet him that day. And so just talking with him about what a doula is, talking with him about what his experience as a father is, being a new father, it was just actually really inspiring, but then also very kind of, I felt really good being able to talk to someone who was not aware but then became aware to the point where he was willing to be in the video and talk about even one sentence just saying, I support advocates, right? Going from being nervous to even be there to then sharing with us and then doing a short little clip for us so that other men might be attracted based on his experience. So just wanted to share that. Please feel free to contact us with any other questions, or of course, we're going to talk now. But if you have any questions or you want to see more about the organization, please come to our website. There's also a whole other side of pipeline programs, academic stuff for those young folks in high school, college, and in graduate school who are interested in being in health professions. If you know anybody who would benefit or be interested in coming to the Advocate session, our next one is tomorrow. They can register, and we'd be more than glad to welcome them and hear their stories. Thank you.